I'd like to ask you, Andrew, a couple questions. One is, do you ever use tissue diagnoses like electron microscopy of collagen? And are you aware of any center that actually uses that to actually look at the collagen?
No, I'm not familiar with that, but that sounds like a very good approach with biopsies and such. Yeah.
We actually have two investigators in Toronto who do electron microscopy and spectroscopy, and they are going to be doing some further work in that area. Can I ask you, in California where you work, is this something a family physician feels comfortable approaching, or do you have a network of specialists who help with sort of coming up with the diagnoses?
Well, I think the purpose of our conferences and these talks is to make the family physician more and more comfortable diagnosing this and hopefully developing some of their own network of the specialists that they'll need for these patients. I struggle every day with my network. I mean, I find um, gastrointestinal specialists, neurologists, and interventional radiologists, and develop my own network. But these doctors come and go, and so sometimes it's reinventing the wheel again and again with the network I have around me. And so I think it's a really good idea that the primary care providers start to develop their own network as well.
Yeah, I'm finding much the same area that I'm more of an internal medicine specialist for children, as I'm sure you are, as opposed to just being a cardiologist. But these patients will enter some field, whether it's the surgical route, the headache pain route, the GI route. They're coming in with their major issue, and then you start asking about hypermobility, and then you get the family. And what I'm finding is I'm truly using a spectrum similar to what you're talking about with hypermobile EDS and the spectrum disorders. I actually just make a continuum. I don't believe they are two separate groups. They are truly a spectrum. And you ask, how much does the mother fit on the spectrum, or the father, grandmother, child? And this child is half his mother and half his father in genetics. They may get diluted, or if the other parent has issues, the child is the worst patient, whereas the mother or father may have part. But it is tremendously interesting to see how these children are formed genetically. And I'm not so sure about trying to put people in boxes or circles or whatever. It is truly a spectrum, and I think that's hopefully someday we can get away from trying to be so exact. I think, because I think each individual may be heavy on this area, light on this area, and these are criteria that are just criteria. They're going to keep changing every 4 years or 5 years. And yet, I think when we have a genetic diagnosis, when we have tissue diagnosis, when you have assessment of all those areas, the individual will be the individual. But I do realize for assistance in healthcare costs, schooling, disability, workplace environment, sometimes it is important to come up with a diagnosis that will support that person financially. A lot of my families are requiring financial support, especially the young kids when they become into the young adult life. They need support.
So I'll just interject here, and I totally agree that, Andrew, that was a very cogent and very clear talk. It's so helpful to see it delineated that way in the chapter that you wrote, in Disjointed is still a major reference, even for myself, to kind of still continuously sort this out. We do have some questions from the audience, and just to clarify for the participants, the healthcare professionals have the capacity to ask their questions verbally, and for the patients, for the people who participated today as patients, you will be able to ask your questions in the chat, and we will address those as best as we can after the conference is concluded. But Annie, registered nurse, actually has a question for us first. So Annie, go ahead and ask your question.
Again, thank you for this day, these presentations. It's so validating. I am a registered nurse for almost 50 years, and I have a child with multiple, like 15 plus diagnoses. And we keep having doors slammed in our faces. And I guess, and I've recently spoken to somebody yesterday whose daughter is 16, multiple diagnoses or symptoms and can't get help. Pediatricians won't return their call. And I'm so curious. I see it every day in my work. I see it every day in the community. It's almost a resistance to learning or to taking it on. It's like, oh, does that mean I really have to know the vagus nerve? I'm trying to understand how it is that all this research is out there and growing, and yet there are a lot of people that are not getting seen or gaslit. And I want to know how to talk to physicians and specialists so that I get their attention as a professional as well as a parent.
Yeah, I don't want to rant too much about the current state of the medical system, but I think there's two major driving forces that lead physicians to shun these types of patients. And one is, of course, the amount of time they're allowed to spend with the patient. And so, if a 15-minute visit doesn't have a 15-minute problem in it, then they need to, get them out the door as fast as they can. And the other is the siloing of medicine, that we're, particularly as medicine is becoming more and more institutionalized, physicians being, cogs in a very large institution where they're discouraged from crossing their silos. So a pediatric cardiologist should only be managing pediatric cardiology problems and nothing more. So this is very, it goes against what these patients need. A pediatric cardiologist, just as Dr. Roland said, is, has to step outside that. They have to be the internist. They have to be the general practitioner, taking care of the GI issues as well as the neurologic issues, as well as the pain issues. So they have to step far outside of their silo to take care of these patients. And until that is encouraged and a physician is not put at risk to do so, then we're going to keep on seeing this kind of thing.
How can I help them? Like, there must be something that families can do or as a practitioner, and then as a nurse navigator, how do I, is there some form or chart or make it easy for them so that I'm not asking the physician to do all of the work or asking them to take on all of the risk? Is there a way, or when your patients come to you and do something, is there something that stands out?
If I can make some gentle suggestions, for sure, because you're trying to navigate a system where complex patients aren't given the time. If you look in the package that accompanied this conference for some of the cases that we shared with you, you'll see things like the body map, right? This is a very nice way of you potentially, for example, with your daughter, going through and highlighting the symptoms that are affecting her. Then, of course, this conference has made a lot of efforts over the years to publicly share the presentations that were provided by former speakers. So if you think your daughter sort of has more of a dominant phenotype, whether that's MCAS or hypermobile spectrum disorder or whatever, is, asking your physician, okay, maybe we don't have time today, but this is what I think is going on. I know it's up to them. You can't oblige anybody to take that on because it is a strained healthcare system. But then linking them to presentations that have been posted, whether it's Dr. Maxwell's talk, because you need to provide them the educational opportunities, or providing a research article that, you know, have often been referenced in some of these talk, and just saying, look, I understand you may not know much about this, but this is kind of what we're thinking. And, you know, if you think you're willing, you know, and being mindful that they have their own stressors. Like, this is not something that most people can go down a rabbit hole. And just as Dr. Maxwell said, you know, we end up having to play multiple specialties. I actually somewhat resent when I have to play gastroenterologist and there's very little curiosity on the lack of the gastroenterologist for the GI symptoms. And it's like, okay, well, I don't know much about SIBO, but I guess I'm going to learn, right? But that's, you know, how it goes. So I want to make sure there's time for a couple more questions because we have another 12 minutes. And Gail has her hand up and has a question. And then after that, Heather Beck has a question.
Yes, thank you very much. Thank you, Dr. Maxwell. That was a great overview. I have a specific question, but first I want to comment on your last slide. It was nice that you brought up maybe we should reconsider family history, because in the 2017 classification criteria for hEDS, it's even, they have to be a first degree relative. And so we've had patients that had all the other criteria excluded because it was their aunt or their cousin who was diagnosed, and when we know the problems like Annie just brought up, I mean, you know, it's so difficult to get into the system and be diagnosed. So even if it's a second degree relative, most likely the other affected members of the family, TDS or hypermobility spectrum disorder. And also, I'm a genetic counselor, and that's where I see how EDS is considered differently than other hundreds of symptoms that we know in genetics. Other symptoms in genetics can be multisystemic and complex, but you know, if there's some criteria, some symptoms are met, we give the diagnosis. We don't wait till all the symptoms are met. And it's so I'm, you know, as a genetic counselor, it just bogs my mind that we see EDS so differently. But I have a specific question for a cardiologist, and it's about erythromelalgia. I've seen patients who contacted me about that symptom. And finally, you know, looking at the whole picture, they did have other symptoms of EDS and were even diagnosed afterwards. So it happened to me a couple of times. So I don't know much about this. I'm in genetics, but what's your answer about that as erythromelalgia as a symptom?
I mean, it seems to be some combination of you know, Raynaud's with mast cell activation syndrome, like and maybe CRPS is very similar as well, where there's mast cells that are actually aggravated in pain nerve fibers in peripheral tissues. And so this combination of a vascular dilation slash vasoconstriction with a pain component that's probably driven by mast cells. So I wonder whether, you know, we'll have some success managing erythromelalgia, thinking of it in those terms.
Thank you very much.
As a professional anecdote, I have had success treating erythromelalgia with mast cell activation approaches. The first thing that I tried was topical Benadryl after years of having pain. It was the first thing that completely relieved her pain for short periods of time. And that's how I knew I was on the right track. Yeah. Heather Beck.
As an RMTA, I see people with constant subluxation of the ribs, etc., or other hypermobility issues. For those that have a primary care provider, I have given them the chart, that body chart. But what do we do for people that don't have access to primary care? Many of my patients' clients don't have a doctor or a nurse practitioner.
I don't even know where to begin with that question. I mean, obviously they need to have some sort of medical attention. Are you saying that all their care is massage therapy, or?
No, they'll see chiropractors. If they've got coverage, they might see osteopathy or naturopathy. It's just we have a shortage of doctors and nurse practitioners in Thunder Bay, and we are better staffed than many of the outlying or more northern communities.
Yeah, I mean, I think, these patients are oftentimes so complicated that they're going to need providers. Usually a primary care provider is the first place to start looking for the subspecialists and coordinating the subspecialists. If there's a way to get to someone who's EDS savvy, that would be helpful, even if it's, a long distance. I mean, telemedicine is becoming more and more accepted. So perhaps these patients that don't have them locally can work by telemedicine with EDS savvy providers.
Is there an online service that we could recommend, like an online physician or something that could follow them to help them facilitate a diagnosis?
The various EDS networks have lists of providers, and some of these work by telemedicine.
Okay.
I think the challenges there too is that most physicians who provide that kind of care are only able to provide that care in a certain geographic region. So, I mean, that sort of speaks to a greater health care system issue that I don't know that poor Dr. Maxwell will be able to comment on. A very different environment probably in Northern California than in a remote area in Canada, but yeah.
We have our challenges too, and I don't think they're any less than what you guys are experiencing in Canada. But yeah, I mean, perhaps maybe during our working session, this will be some of the things we talk about, is better access to care.
I think Heather, I have a patient in Sudbury who told me her son is going to be the first complex care patient at a Sudbury pediatric program at the hospital there. So I think, and I've heard this word from a bunch of people today, it's really complex care where you need a multiple people. No one person is likely going to be feeling comfortable enough to coordinate everything here until they get training in physiatry or rheumatology. Like this, you need training in almost every area to look after these patients. And many of us have gone into our subspecialties, and it's been very hard for me to, I now prescribe metformin, low-dose naltrexone, ketotifen. I prescribed these in the last 2 months for the first time in my life, because there is no one who's around to see these children, or they're going to wait so long, the waiting list to get into some subspecialty programs. So I think we need to develop a complex care network that will include these patients plus a whole bunch of other patients. But really, I guess we need to get to our health departments. In Canada, we have, government health departments, and we need to set up complex care spokes and hubs throughout the province. And so rather than leaving it up to nature and who's interested, and then they get married and move away, now you've lost your key person.
We have here some rapid access clinics. You still need a referral there's one for the knee, there's one for the hip, there's one for the back and other conditions. Would it eventually become something like that, where there could be a rapid access where perhaps a walk-in doctor could make the referral if they suspected something?
In a perfect world, yes. So I think it speaks to sort of, a lot of it is education first. People can't diagnose what they're not looking for. So, or that they've never been taught in med school. I had one slide on mast cells in medical school. I had one slide on connective tissue diseases, and it was focused on Marfan syndrome. So, I mean, not that there's a lot to learn in medicine. And I think there's this overwhelming and constant pressure to include more in the medical curriculum. And certainly, I don't know that there's a perfect answer, but it's things like this where you bring that forward and you're challenging your own doctor to kind of explore these things that will get it there. Like, I had a couple exposures in my early pain training, and that's the reason I'm now doing this. So you never know which learner is going to be that then runs with it and ends up, being that resource for a lot of people. I see Annie has her hand up again. Go ahead, Annie.
Oh, hi. I wanted to touch on the medical school, and how can we encourage, I mean, from the bottom up for more coverage. I've talked to family doctors who I've known most of my working career, and oh, it's really rare, and I think the one thing I've seen make a difference is when I say, if you can't connect the issues, think connective tissue. I used that recently. My brother recently passed, and with the ICU doctor, and it was like a lightning bolt went off in his head when I started to relay some of the things that he was experiencing that I could see. And I'm just wondering, as a practitioner or as a member of the public, besides voting, um, how can we, like, does letter writing help? Does showing up at certain functions help? Like, how can we support this learning and increase in knowledge in the people that we need to have it?
Is that directed to me?
Or whoever will be brave enough to take it, yeah.
Yeah. Well, I think conferences just like this are one of the most important things we can do, and particularly putting these lectures on, publicly accessible media. So I think that's one of the very best things we can do to get the word out on just how frequent these diagnoses are, how they overlap between the different entities. So I think that this is one of the best foundations I've seen that freely presents the lectures that remain available for years afterward. And so I think we just need to keep encouraging that.
I would say that I have approached Queens, and that I have a personal contact there, but I do believe the answer is to get this in the curriculum, and you can get it at all levels. So when they are in this just physicians, it should be physios and nursing, rehab, all the other especially even chiro and a few other areas. And that it can go into their basic training education. Then when they are into their postgraduate training and the different levels, residents, family medicine I have access to family medicine residents. It's a little bit of the time, but I'm going to talk to Andrew about this later. The talk he gave today could be a basis for a core topic on review. I think if every physician in Canada and the United States, Andrew, listened to your talk that you just gave, they would come away with so much more knowledge. And then these patients who come in with these mystifying, I can't figure you out, you're too complicated, my brain can't take it, my time can't take it, my devotion can't take it. But listening to almost like a core talk, this could be extremely useful. That's why I'm so happy that you were invited back, and I'm so happy that you gave even further information from before, especially on the spinal areas, which I have several patients who are presenting with all sorts of vagal symptoms and venous congestion symptoms. We're finding some neurosurgeons in our province who surprisingly actually can look at these areas, but there's a lot of neurosurgeons that won't touch these patients. We're having to send to the United States because fortunately down there you do have some centers of excellence, but I think they're growing. These are little nutshells that are growing on East Coast, West Coast, and in Canada, unfortunately, we're quite behind you.